All right. Good afternoon, everyone, and welcome to today's webinar, Medicaid's Early and Periodic Screening, Diagnostic and Treatment Benefit, a powerful tool to improve child health, brought to you by the Network for Public Health Law. I'm Sadia Mohammed, the Marketing and Communications Associate at the Network for Public Health Law's National Office, and I will be your host for today's webinar. Just a quick note that both the presentation slides and the video playback for this webinar will be available on the network's website shortly after the conclusion of today's event. Please feel free to submit questions at any time during this webinar by using the Q&A tab on the right-hand side of your screen. All you need to do is click on that tab, select all panelists from the Ask drop-down menu, and submit your question. Your presenters for today's webinar are Sarah Summers, Managing Attorney at the Network for Public Health Law Southeastern Region Office, and Jane Perkins, Senior Staff Attorney, also at the Network for Public Health Law's Southeastern Region Office. Sarah will be leading us through the rest of today's webinar. So Sarah, over to you.
Thank you so much, Sadia, and thanks everyone for joining us for one of our favorite topics, Medicaid's Early Periodic Screening and Diagnostic and Treatment Services. I'm going to start out with a little background on Medicaid. For some of you, this will be old news, but others may not be as familiar with Medicaid. Medicaid is the federal and state cooperative insurance program for low-income people, and it covers millions of Americans, adults and children, and it has the potential to cover a broad scope of services. And for children, it mandates a broad scope of coverage. The structure of Medicaid is that it is a cooperative program in that there are both federal and state laws, regulations, and procedures that govern the program. Also, the federal government matches at least 50% of the funding that states spend on services, and in lower per capita income states, it matches much more. It has a federal agency, the Centers for Medicare and Medicaid Services, or CMS, that oversees the program, and it also will have a single state agency that's responsible for it. So in that way, it is, it is a combination of two different governmental entities that are running the program. And Medicaid is a program that can be adaptable to fit states, and in that respect, there are mandatory aspects of Medicaid and optional aspects. The first way that this is true is for Medicaid eligibility. Medicaid requires states to cover categories of pregnant women and children, low-income caretaker relatives, generally that means single parents with extremely low incomes, subcategories of people over 65, many people with disabilities, and in states that have chosen to expand Medicaid, what they are sometimes referred to as non-disabled adults. I have that in quotation marks because what this means is that there are people who qualify under the Medicaid expansion who don't fit into a federal disability category, but may also have chronic conditions or disabilities that necessitate care. So all states will have a certain core of people who are available who are eligible from state to state, and then may optionally expand it beyond there to people in different categories or higher incomes. But we're not going to focus so much on that today. We're going to focus on the children, the people under age 21 who are enrolled in Medicaid. Medicaid's optional and mandatory structure also extends to services. There's a big list of service categories here. And there are mandatory categories, which include the big ones like physician services, hospital services, nursing home services, family planning, and the others you see on this list, federally qualified health centers, and of course, Epsdt, which is going to be the focus of the rest of the program. There are other service categories that are optional for adults. Prescription drugs, even though all states cover them, they're optional. Prosthetic devices, dental services, rehabilitation services, which sweep in a lot of behavioral health services, and we'll touch on that later in the presentation. Private duty nursing, personal care, a lot of other home and community-based services are optional for adults, but this is not true for children, and we'll talk about why. Epsdt, not the most catchy acronym, but something that is sort of common at the federal level in the Medicaid world. You have things that are not readily pronounceable as as a word, but this is an incredibly important set of initials that encompass a whole world of treatment that make up a comprehensive benefit. This is a mandatory service for all Medicaid eligible children and youth up to age 21. There's some limited exceptions for that for people who are medically needy, but we're just going to look at the large bulk of children in Medicaid. Generally, when you see a kid on Medicaid, you know that they're eligible for EPSDT. And so we're going to break down each of these initials. Now, the impetus for the EPSDT benefit, which was created in the mid-1960s, was a recognition that common health problems and chronic health problems had a much higher incidence for low-income children. Poor children were more likely to have vision, hearing, and speech delays and problems, untreated tooth decay, high blood lead levels, which causes a lot of damage to children's brains and development, sickle cell disease, behavioral health problems, asthma, anemia. There are multiple redundant studies going back 50 years that show that these have a much higher prevalence and have a much greater impact on poor children. And so that is the reason that the EPSDT benefit is so comprehensive, in many cases more comprehensive than what's available to children enrolled in private insurance. So as I mentioned, there are overlapping and complementary sources of authority that govern the EPSDT program. You have the Federal Medicaid Act. You often have a state Medicaid statute, federal and state Medicaid regulations, sub-regulatory guidance, and we're going to touch on that during the program. There's something called the State Medicaid Manual, which is a long-standing compendium of guidance from CMS. And then there are more recent guides from CMS that pull together guidance into one place. And then there are also managed care really dominates the delivery of Medicaid services, particularly for children. And so Medicaid managed care contracts and all of their provisions also make up the requirements that cover Medicaid. So this is quite a bit, all of these, redundantly reinforcing how important EPSDT is. So, of course, every word that Jane Perkins and I are saying today is extremely important. You should remember every single one. But if there's one thing you come away with here, that is that this is an absolutely key piece of information for anybody interested in EPSDT. This guide, what they sometimes refer to as a strategy guide at CMS, came out in 2014. And it is a resource for states, Medicaid programs, for healthcare providers, parents, advocates, teachers, you name it. And it is a compilation of a lot of written guidance that CMS has issued over the years. And they pulled it all into one narrative, which is very handy and very helpful. And it explains how EPSDT is actually supposed to operate in the real world. And the purpose, and this is the mantra that CMS has been using for years, the purpose of the guidance, the purpose of EPSDT in general is to ensure that children receive the right care at the right time in the right setting. And that's what EPSDT is all about. I've given you a picture of the guide and the URL is on the cover, but if you want to find it, it's just as easy to put it into a search engine, EPSDT, a guide for states, and it will probably pop up pretty quick. So throughout this presentation, when there's something that I'm highlighting from the guide, I will let you know that. But I can't stress enough, this is an incredibly helpful explanation of the benefit and of the extent of it. So what is EPSDT? E stands for early. The point being that you need to get in there when children are young and stop health problems before they get more serious, treat illness as soon as it arises, and provide the preventive and diagnostic services they need to stay healthy. So we're going to start with the screening, EPSDT. The EPSDT requires that different screenings be provided at preset periodic intervals. The first and the most important is the medical screen. And it is required that it contain these elements: a health and developmental history of the child, an unclothed physical exam, meaning like a thorough physical exam where the child is fully checked, all the necessary immunizations that are recommended at that age level, lab tests, including particularly lead blood tests, And finally, age-appropriate health education for the parent or the child. This can be education on safety, on using a car seat, on nutrition, on the appropriate amount of developmental phases when children should be walking. All that should be rolled into the screen. Sometimes this is referred to in common parlance as a well child visit, but it's important that none of these things be lost. These all need to be given pursuant to the statute, and they also that generally states require that that has to be given to get reimbursement. I see a question, Jane. Is that something I should get to now?
I'm not seeing a question, sorry.
Okay. Let me look real quick. Oh, someone pasted in the guidance, thanks. Is there any possibility of mental health screenings being added to the list? This is, the guidance makes it clear, let me jump back to that slide. The guidance makes it clear that just because it's called medical, it includes a mental health component, and that the health and developmental history is supposed to be a part, to include mental health. So I'm glad you asked that question, because I need to emphasize that. That is absolutely required to be a part of EPSDT. There are also other screens, the vision, hearing, and dental screens. And this is a screening for if children need eyeglasses, for a hearing test, and then dental, which the statute says has to be provided for relief of pain, restoration of teeth, and maintenance of dental health. And so the screening ties closely to the need for treatment. So let's focus on the P, periodic. There is a schedule based on a child's age that states devised with the help of experts, expert recommendations that are based on their age, and they are different for medical, dental, hearing, and vision. They may vary from state to state, and they do vary based on age, but the states are advised by CMS, by guidance, to look to experts' advice in the area. For example, the Bright Futures has a periodicity schedule. The American Academy of Pediatrics is a common resource for this. There's also the American Academy of Pediatric Dentists for the appropriate intervals for dental screening. And so the states will come up with a periodicity schedule, and once a child is enrolled in EPSDT, their family is supposed to get notifications for when the next screening is due, and there are certain components that are supposed to be a part of it. But it's not just, you don't just have to come in on schedule. There are screenings known as interperiodic screenings. And these are screenings that are outside the periodicity schedule, but they're just required based on evidence of a medical need. And importantly, this doesn't need to just be diagnosed by a physician or a dentist. It can also be by another professional who comes in contact with the child, someone in the WIC program, someone in the SNAP program, someone in the schools. So this is a very important part of EPSDT. And this is the next jump in the link is to T, the treatment. Once you're diagnosed, you are entitled to all necessary treatment, the need for which is revealed by the screening. And this is, I'm emphasizing this because this is in the statute, and all necessary treatment that is described in the Federal Medicaid Act, regardless of whether it's covered for adults. And it has a broad medical necessity standard that we'll talk about in a few slides. And that is that treatment must be necessary to correct or ameliorate physical or mental illnesses and conditions, even if the service is not covered under the state plan. Correct or ameliorate, we're going to talk about what that means in a minute. But first, let me just take a side trip and talk about services. This is a list of the services that many of which are optional for adults, but are mandatory for children when screening shows a need for them. That includes all types of therapies, physical, occupational, and speech therapies that may not, in some states, are not covered for adults. And even if they are, may be covered in such limited amounts that they wouldn't meet a child's needs. That can't be that way. Private duty nursing, in-home nursing is also covered. Rehabilitation services is a broad category that I want to focus on for a minute. Rehabilitation services, of course, people think of it as physical rehabilitation, which is included in rehab, but it also includes quite a bit of mental health services. They fall under the rehabilitative services categories. It can also include nutrition services. And I'll take a minute about nutrition services because we got a question before we put this webinar together. And nutrition services can be covered. There's certainly assessments and education on nutrition need to be covered as a part of just the general screens and health education part. But also nutritional supplements can be covered if they are necessary to treat a condition. It's not just something that becomes medically necessary because it's prescribed by a doctor. And this is not just, generally healthy food can be covered by Epsdt, but if a child has a particular medical need that necessitates coverage of nutrition services, then that needs to be covered. Okay.
Sarah,
Yeah.
we have a question about dental. When you have a moment to just comment on dental services relative to the other services.
Yeah, Deborah, I see your question about dental. I I'm tempted to sort of, well, no, we can get into this now. I was going to say I'm tempted to push this towards the end because we can have a longer discussion about it, but let me just answer this and we can talk about it at more length in the Q&A period. Dental services are a big problem in Medicaid, particularly for adults, but for children as well. There simply, in many states, are not enough dentists who accept the Medicaid rate and will provide services for children. Some states have, and as you say, states have expanded practice to include services from dental hygienists and the and other, professionals who are not at the level of, having a DDS. This, speaking from the eye, my personal opinion, and I think many experts agree, this is a very good thing. This is particularly a good thing for rural areas. It is a way to extend the access to dental services. Are there efforts to acknowledge that the goal of screening and referring is more appropriate and cost-effective than by a dentist? I think it's more about accessibility as opposed to cost effectiveness, but I think that may vary from place to place. I would also say that this can be a real battle in a lot of states because dentists don't want to see the scope of their practice expanded. If there's anybody on the call who's a dentist and who takes Medicaid, I'd always be interested in hearing from you on this. There was a lawsuit a number of years ago, Jane, maybe like 10 years ago at this point. Does that sound right? Time passes so fast, but there was an attempt by in Alaska to have a particular kind of community health worker, community dental health worker, perform more than just exams and cleanings, but also be able to do extractions because of the rural, frontier nature of Alaska and the extreme difficulty they had getting regular dental care. The American Dental Association sued for saying that it was an impingement on their practice. And the suit was ultimately settled, and there's a special category for Alaska dental health therapists that are still covered, but it wasn't expanded more broadly than that. And it's always a battle when you're trying to expand licensure for not just for dentists, but for other kinds of professionals. And the question, I'm not a relative of Herman Summers. And then providers, Kimberly asked whether providers are telling families they skip the visit. I'm interested in what's happening other places. Let's put a pin in that question for the discussion later. Anonymous attendee asks about diagnosis and behavioral health. We're going to talk about behavioral health later. And so I'm also going to put a pin in that. We're going to talk about nursing and services in schools. And we'll also talk about PRTFs later. OTC medications can be covered under Epsdt, right? Jane, that's your bailiwick.
Correct.
Thank you. Just trying to shake up the speakers here. Okay, so let me see if I can, okay, let's talk about the standard for correcting or ameliorating. This is, if some of you may be familiar with medical necessity definitions in private insurance, and it may have a number of factors like, it has to be, it can't just be for convenience of a caregiver. It has to be, the best treatment available. It has to be, it has to be the cheapest treatment available, whatever. These EPSDT it has to lead to improvement or something like that. These things may conflict with the EPSDT definition, which is intended to be broad. If it fits into a category of services, then if it's necessary to correct or improve or maintain their health, to compensate for a health problem, prevent it from getting worse, or prevent development of additional health problems. So that's a pretty broad definition. But now we'll talk about what sort of the qualifiers are on this. So who decides what's necessary to correct or ameliorate that piece of it? The determination, CMS can't emphasize enough, it needs to be individualized. You can't just say this type of kid with this type of condition should get this type of treatment. There needs to be an individual determination to see if that's actually the case for a child. There can be utilization review that says, generally you need 5 physical therapy visits for this condition. But if a provider determines it's medically necessary to have more for that child, that has to be taken into consideration. There's long been, sort of a push and a pull about who decides, who has the ultimate say. In the CMS guide, they say the treating provider has a responsibility for determining it, but both the state and the treating provider play a role in determining whether a service is medically necessary. Exactly what that role is, the bounds of that may be somewhat blurry, but ultimately, if there's a disagreement and the beneficiary or family wants to take it further, then they have the right to a fair hearing to dispute a denial of a service. Jane, is there anything you want to add to that?
I don't think so. I think that's good.
All right. Okay. There are other limitations as well. The sky is not just the limit. CMS has said that states can restrict treatment to an equally effective or less costly alternative. There has to be a service listed. The service has to be listed in, that's the statutory provision, 42 USC 1396 DA. So it has to be the category, fit in within a category. And states can restrict treatments that are experimental. Now, simply because something is rare doesn't mean it's experimental. People can, have the opportunity, a provider or a family in an adversarial position can explain why this rare treatment is actually medically necessary for the child. But these are the limitations that states are allowed to put on it. And of course, treating providers generally who are recommending a service are certainly licensed in the state or qualified under state law, and for the most part are Medicaid providers. So there's already that bit of, of a safeguard as well. So just a few words about services that they need to be listed in the Medicaid Act. So, but that doesn't mean that particular name of the service has to come in the Medicaid Act. For example, incontinence supplies are covered, but the Medicaid Act doesn't say incontinence supplies. It has to be fit into like a categorical box. For example, assisting a child with a disability with basic living skills, that can fall under home health or under rehabilitation. Swimming can, if it is supported correct, with a recommendation from a provider and medical necessity, can, possibly be covered as a physical therapy. Crisis intervention is a rehabilitative services, and there are a host of behavioral health services that come under that heading. Maintenance service can be private duty nursing, can be personal care services. And again, as I mentioned, incontinence supplies fit under home health, durable medical equipment, or supplies. So it is not simply, it doesn't simply need to be named, but it needs to logically fit under the category, and in some cases be backed up by evidence or licensure or law. So just to review, and then we'll take a minute to go through the questions again. The basics are, you need to cover all necessary treatment. that needed to correct or ameliorate that's listed in the Act, regardless of whether it's optional or mandatory for services. There needs to be an individual determination of need, the right treatment, right setting, right child, right time. And one of the things that is important about EPSDT is that the state is required to ensure a broad base of qualified providers. This goes back to the question about dental. This is something that is problematic and states really struggle with, and that it really hurts beneficiaries that there may not be a broad enough base of dental providers. And so one could argue, and Jane and I are also advocates, that, you know, it's part of your duty to ensure, if you can't get enough dentists, that you need to have enough of the properly licensed providers who can provide the services. At least that's what I'd argue. And as I mentioned, you can have utilization controls, you can have tentative limits, you know, you can have require prior authorization, but it can't interfere with EPSDT's quote preventive thrust. You can't require pre-authorization for screening, because that would defeat the purpose. Okay, so let's go back to the questions. And Jane, please, you know, help me jump in. Let's see, we talked about dental.
There is a nursing in schools question, but I'm assuming you'll want to save that for when you're talking about schools. What kind, and you've got a data question, the data slide coming up here. I'm keeping an eye on them. I think we'll be talking about behavioral health services in a moment. Could referrals to SNAP or WIC be considered part of nutrition services under rehab?
Well, I would think it's part of case management, Jane, wouldn't you?
Yeah.
Yeah, so I think it's an EPSDT covered service. I think it would either be encompassed in just the concept of the you know, the screen, or it is a case management service. So one way or another, it should be covered. And there's not a statutory requirement, but in guidance, they, you know, repeatedly tell states they need to coordinate with entities like WIC and SNAP and Head Start to make sure services, you know, that kids get the services they need. All right. I think I was messing around and now I've gotten out of order with my slides. Okay, sorry about that, y'all. Another EPSDT requirement that isn't encompassed in the acronym is about outreach and informing. States are required to make sure people know about Medicaid and EPSDT, otherwise how can they get into the program? There has to be effective and aggressive outreach, you know, both oral and written, translated, available, you know, for people who have limited English proficiency or who have, you know, disabilities, you know, vision impairments. It should be targeted, particularly to like low medical use populations, you know, pregnant teens, and states have to ensure that there's transportation and appointment assistance given by the program. And there has to be coordination with other entities. That's where the WIC and the SNAP and the other pieces come in. And so they can't, there's, you know, CMS has said, and there's quotations in cases about EPSDT systemic claims where you can't just expect people to present themselves. Otherwise, if you don't get out there early and make sure they know it, then they may be first presenting for care, quote, on a stretcher. So now reporting. We had a question about data. Please run into my hands because we were already going to talk about it. There is a form called the CMS Form 416, and that states are required to monitor and report the number of children who get any kind of screening service, who are referred for corrective treatment, who receive dental services, or for little kids, whether they've received lead blood testing. And that 416 form, you can go onto CMS's website. Again, if you just put into a search engine, EPSDT form 416, a web page will come up and you can find the 416 forms for every state for every year going back to the 90s, I think. Isn't that right, Jane? And then there's also one nationally. And this is a very valuable, you know, pretty, not completely real time, but it comes out pretty quickly to let you see what happened the previous year. And it's an excellent source of information. It's limited, you know, it would be great if they had gathered more, but this is a very nice snapshot of what's going on. And we have a publication, and when Jane's talking, I'll get the link for you, where we call it the EPSDT chart book, where we compile all the 416 information and make, graphs and charts comparing these various figures from state to state. And that is a free publication available through our website. Jane, were you going to say something? You came off mute.
Just right quick on, just to clarify, when Sarah's saying us and we there, it's in our other hat as attorneys with the National Health Law Program. That information is available on that website. There is a follow-up question in terms of how does CMS track implementation of the T in EPSDT? Do you want to talk?
Yeah, I was going to say not as comprehensively as we might like. They collect the numbers of being referred for corrective treatment, and outside the world of the 416, there are CMS is developing and expanding the use of what they call the core measure sets, and their adult and child core health measure sets. And these measure, they're not yet mandatory in every state, but most states are using them to some extent. And while that isn't, necessarily restricted to Medicaid, it gives some insight into what kind of treatment children are getting. So not, I would say you may not be able to, I would say we can't get as maybe as clear a picture as we like. There may be other ways to get at the information on a state-to-state basis, requesting encounter data or something. Jane, do you have other ideas?
Well, there's the TMSIS data, but that has, I think, lots of problems. The core set is, I agree with you, Sarah, that's the major treatment-oriented data. And it can give very good indicators like readmission after within 15 or 30 days after an inpatient psychiatric stay. Any of that data, I think all these data sources, the 416, the core set, TMSIS, external quality review reports, all of them serve their own purpose, and none of them can replace any of the others. Sometimes we hear that for example, the core data set could replace the 416, but it can't, because the 416, as Sarah said, is pretty close to real time. It's in April 1st of each year, whereas the core data set has about a 2-year lag. Those are the main national ones, and I agree with you, Sarah. There are some state data sources from state to state. Fair hearing data on fair hearing complaints and treatment complaints and services is a state-based data source.
Yeah. And someone asked a question: referral for corrective treatment doesn't necessarily mean receive treatment, does it? That's not what the metric is. That's not what they're tracking. I think the assumption is you get the treatment, but as you say, if the family can only be referred. So
that's also, we've done, just through some of the other work that we've had at the National Health Law Program, done a little bit of, over the years, deep dives into the referral for corrective treatment cell on the 416, and it's one that is not well understood or policed, and I think the accuracy on it is an aspect of the 416 that's questionable.
Yeah, I think that's fair. For reporting, there's a participation goal. One was set by statute long ago that there be an 80% participation in getting the screening. It hasn't been reset in a long time, and with some states meet it, some states don't. It depends on it, and it can vary from year to year. It's not something that I'm trying to be diplomatic. Most states haven't really gotten there, but there aren't any consequences for it. It's just a benchmark that states are trying to meet, and There are other types of benchmarks that CMS are moving towards, connected with the core set.
Sarah,
So-
quick question. These various data sources, are they disaggregated by race?
No, okay, and that is a very important question. And Jane mentioned something, and this is perhaps a webinar for another day, a hardcore data dive. Jane mentioned something called TMSIS, and this is something that CMS is really turning towards as its data world, and it is available, but it is. When you go to if you go to the TMSIS data, you get like Excel spreadsheets, and there are different ways to sort it. And it's certainly not, I wouldn't say it's inaccessible, but you need to know something about Excel, and you need to know something about data to be able to figure it out. I think it's primarily useful to researchers and to CMS itself. And I think that there are ways that it can be sorted and disaggregated to try to reveal some of the racial disparities. But it's not something you could just click on and see, broken down automatically. Also, data is as good as the data collection, and a lot of states or plans either are not doing it, or may not be doing it, or it may not be accurate. So I think there's still a lot of questions about it. There are a host of new requirements that have come into play requiring disaggregation of data by race. And, so going forward, there should be a lot of improvement there. But right now, it is not, it's very imperfect. There may be your state may gather data as well. So that's another possibility. But yeah, good question. Okay, we're about to go into the special.
Sarah, one other quick question back to nutrition for a second. Under nutrition services, would lactation support be covered to feed the infant breast milk?
I would argue that it is covered under the screening for a newborn screening. I think it should be covered if a woman herself is eligible for Medicaid, that should be covered as well. So I think there are different ways that should be covered and is coverable.
My footnote to that would be, to the extent that there are other programs created to provide lactation support services, WIC sometimes, that those programs should be used for the service. I think people turn to Medicaid very quickly sometimes because it is an entitlement program, and it's an open-ended entitlement for states. But to the extent that there are other programs created to cover services and activities, those programs should be used for those purposes, so that what the EPSDT role in the first instance would be to make a referral to those services and programs so that the child and family can get what they need there.
Yeah. Okay. So we're gonna move into special topics, but I wanna pick up on this screening question from Julie. Can you say more about what kind of screening in WIC counts? Does it have to be by an RD or an RN, or can a paraprofessional do this? This is the screening is not generally done by WIC. It's done by it's done by a physician. I think it could, I think in some states, like a nurse practitioner or a PA might be able to do it. I don't think a non-clinical professional could do it. And I don't think that WIC is responsible for doing it. It's more a matter that what I was trying to say was that as part of the screening, people could be referred to WIC, or WIC professionals could say, hey, this child needs a let me back up. The periodic screenings are not done by people in WIC. The WIC professional could trigger the need for an interperiodic visit. They could say, hey, something is not right going on developmentally with this child. This child should see a doctor. And that would count as an interperiodic screen that gets the child into the EPSDT system. Does that make sense? If it doesn't, just say something in the chat and we can talk about it more. Okay, Jane, you're on. Your camera's not on if you don't know that. So we're going to move on to special topics. in EPSDT. And the first one is medically complex children. Jane, take it away.
All right, thank you, Sarah. Hi, everybody. I'm going to talk about two special topic areas, as Sarah just mentioned, medically complex children and EPSDT, and then talk a little bit about children with behavioral health and serious emotional disturbances and EPSDT. And these two slides are giving three pieces of information for both of those topics: recent federal policy developments, recent case developments, and recent research developments. On all three of these, there are multiple examples, multiple answers to those developments. So this is really just an EG. We're happy to provide more information to you offline. So turning to children with medically complex conditions, there was on August 1st of this year, CMS disseminated a Dear State Medicaid Director letter regarding health homes for children with medically complex conditions. And this is implementing a provision that was in the a piece of 2019 legislation, and it established a new section to the Social Security Act, Section 1945A. These health homes are now optional for states to put into place for children as of October 1st, 2022. And with these health homes, states can provide care coordination, care case management, patient and family support, and similar services to really support a family-centered approach to care. As those of you who have worked with children and families with medically complex conditions, you know that there is a lot going on, and it's a very stressful and complicated situation to manage multiple nurses and personal care services and medical equipment services and and other children. So having care, case coordination, and family-centered health homes are extremely important. The children who qualify for these, if the state does elect to put this option in place, are, as I said, children with medically complex conditions. But just to be clear, that does include or can include children with serious emotional disturbances. These services, these health homes, are in addition to EPSDT. So everything that Sarah said about EPSDT in terms of what it covers, what it's mandatory for the state to do, what the obligations are, those all remain in place. This transmittal is, or Dear State Medicaid Director letter, is an extensive one. It's 15 pages long. It goes through provider qualifications, reporting, service standards, and also talks about the enhanced federal matching funds that states can get if they set these health homes up. So we do a lot of advocacy in the National Health Law Program on behalf of children with medically complex conditions. There's a lot in this Dear State Medicaid letter to digest. So we highly recommend reviewing it. In terms of case developments, the example here is a case from the 7th Circuit that we actually at the National Health Law Program partnered with state advocates in Illinois to do, OB versus Norwood. And in this case, children with medically complex conditions had been determined by the state Medicaid agency to need in-home skilled nursing services, but they weren't getting them. So these children brought a case against the state Medicaid agency under the Medicaid Act, citing a provision of the EPSDT law that requires the state Medicaid agency to provide for arranging for, directly or through contracts, the treatment services that children need. And the case also included claims under the Americans with Disabilities Act and another disability law, because the clients in this case were facing a very serious, some of them a very serious risk of institutionalization. Others were cycling in and out of hospital settings because they weren't getting the in-home services that they need. The state took the position initially that the role of the Medicaid agency is to pay claims. It's an insurance company. And the Seventh Circuit rejected the district court, and then in affirming the district court, the Seventh Circuit rejected this sort of straitjacketed view of Medicaid, particularly for children, because of the Epsdt program, and said that the state can't leave it to families and parents to search for services. They have a lot on their plates. They may not be competent to conduct a timely and effective search, and the Epsdt arranged for a requirement puts an obligation on the state to affirmatively go out and look for and help families locate and put in place in-home skilled nursing services. There are other cases that have followed OB in other states, so that opinion is not a standalone. In terms of research developments, I just arbitrarily cited you to the recent Manette report, Keeping Medicaid's Promise. We like it because it has some nice best practices in it and suggestions for how to get services out to children and to their families. But there are certainly other examples of recent research out there, and we're happy to give recommendations or to help with that if you're interested in finding out more research. Next slide. The other area that I'm going to discuss before, and then I'll hand it back over to Sarah, is children with serious emotional disturbances. Up until last week, in working in this area, we really did rely for federal guidance on a document. I think it was from 2014. It was a joint communication from the HHS, CMS, and SAMHSA, and it is excellent on coverage of services for children who have behavioral health needs, but it had become somewhat dated. So last week, or roughly last week, on August 18th, CMS issued an informational bulletin called Leveraging Medicaid, CHIP, and Other Federal Programs in the Delivery of Behavioral Health Services for Children and Youth. Again, as with the Health Home option transmittal, it's a lengthy endeavor by CMS. It's 13 pages long. We highly recommend you to review this if you're working in this area. There is in it, and we like it because it begins with a nice recitation of Epsdt and really goes through what Sarah just said in terms of what this program requires. Again, emphasizing that necessity is determined by whether something is needed to correct or ameliorate the child's problem. So you're not applying the adult medical necessity standard. You're determining whether something is needed to correct or ameliorate a problem. And that means that the service doesn't have to cure it. They also remind readers, states, policymakers, developmental disability, behavioral health agencies, advocates, that these determinations are made on a state-by-state, case-by-case basis. The remainder of the informational bulletin is to provide a number of examples of how high-quality behavioral health services can be provided and a number of resources for states. One of the things, and I did see a question about being able to provide behavioral health services before there is a diagnosis, and that is something that we see a lot of and we hear a lot of as a kind of a barrier to getting children in. quickly, this guidance clarifies that states don't need to require a behavioral health diagnosis for the provision of EPSDT services, and points out that states can determine that services are needed without a diagnosis, and gives some examples of, I think is from some examples from California as to how they've been working in this area. Again, we commend this informational bulletin to your attention. In the case area, there's I would say it's probably considered an older case now, but it's one that litigants in this area have certainly built upon and used as the model, and as a model in doing this sort of advocacy when all else fails and you can't get agreement to make some changes. And that is a case out of Massachusetts called Rosie D. v. Romney. There's the law offices that did Rosie D. have set up a Rosie D. webpage, www.rosied.org, and there's a great deal of information about it. On this slide, we've provided you with just the legal citation of the case that found the state to be failing to provide adequate screening, and then adequate service coordination, crisis services, and home-based services for children with serious emotional disturbances. There is a remedial plan that is quite detailed and has been studied over time, and the implementation of that plan was shown to improve screening and services in Massachusetts. Much of that, if not all of that, has recently been ended. In other words, the case came to an end. But still, the principles obtained in it and set forth in it, and the ideas of how to address violations that were developed through it are certainly helpful for all of us now. And then a final resource that, again, this is an area replete with ongoing research. The August 18th bulletin from CMS has a number of resources broken out by mental health, SUD, various subject matter areas. But one, I wanted to make sure that you knew about something that the National Health Law Program has done. It's a resource called Addressing Barriers to Behavioral Health Coverage for Low-Income Children. And it is a coverage flip chart. And you can get it at this website address, www.healthlaw.org. And it goes through various pathways for children. If income is this, then you qualify for this. If you qualify for this, then you get this. If you can't get this, then you go here to get that. So it's a flip chart that takes you through various scenarios for how, whether and how children qualify for getting services, and then once they do, what those services are. So that's my couple of slides. I appreciate your being here today, and I'm going to hand it back to Sarah. Mute, Sarah, unmute.
I was so brilliant, though. You missed it all. We have one more slide, then we're going to get to some of these questions. Sadia, I don't know, can we go over a little bit if the questions go longer? Or
Yeah,
we don't immediately go into the ether at 2? Okay. So school-based services. This is a hot topic right now because legislation required that CMS get guidance out on school-based services, including a school-based services administrative claiming guide that's supposed to come out this year. And if you work in a Medicaid agency or a school, this is something to celebrate because it's been a murky area that can cause trouble for states when they're trying to claim for services. So the basic rule is Medicaid services can be covered in school for Medicaid eligible children if the services fit into a Medicaid category. And this includes, but it's not limited to, special education, services under IDEA, special education or early intervention services. And this is great. It's great for schools because instead of having their finite pot of Part B or Part C IDEA funds, they can have the open-ended entitlement of Medicaid for children who qualify. Since I am mortified because I see that the CMS Dear State Medicaid Director letter, payment for services provided without charge, says it's dated 2022, December 15th. That can't be right since it hasn't happened. It's 2014. So apologies for that. But back in 2014, CMS came in and gave some very important guidance to schools, which is that there are services that you may provide free of charge to all kids. Medicaid used to say you can't collect for Medicaid for those services for Medicaid eligible kids. That's a real barrier to getting Medicaid's funding available for services in schools. And now that's been reversed, but it's taking a while for states to implement that because they had a lot of infrastructure in place that made it so they wouldn't do that and then get in trouble later for billing for something that they couldn't. So now they just last week, they have a new bulletin on school-based services that explains to states how they can implement the reversal of free care, how they can bill for services, how they can really get down into the minutia of ensuring that they're not charging for services that are educational. And I know a little bit about this topic, but the Healthy Schools Campaign resources on a guide to expanding Medicaid funded school health services is a terrific guide. And the Healthy Schools Campaign has so much information about this out there. They work closely with CMS, with the states, expanding the possibilities for school-based services. I had a question about school nursing services, and there has been a lot of work done to make sure there is a funding stream for school nursing services. Louisiana is a pioneer in this area. It is certainly allowed if the state checks the right boxes. It just takes a little bit of time to implement it. And they have to be very careful in doing in billing for it. So I am not, I would not say I'm well versed in the minutia of that, but the network has some resources on this, as does again the Healthy Schools Campaign. So with that, I'm going to say thank you for attending. And we're going to stick around for some of these questions. If you have questions and you aren't able to stick around, please email me at Summers, SOMERS, at healthlaw.org. And with that, I'm going to stop sharing and we're going to just get into these questions. Okay, so
Sarah, here's one. I'll kick it off for you because
Super.
we're getting close on time. Are outreach services covered as a separately reimbursed service provided by a community-based organization or a non-MCO provider?
Do you want to answer that? I'm going to type something in the chat here.
Okay, I would say no, not the obligation is on the single state Medicaid agency to engage in outreach and informing, and it can and many states have contracted that obligation over to managed care organizations. They could contract that obligation to community-based organizations. We certainly think that that would make some, just to editorialize here for a minute, we think that would make some sense to be working with organizations that are in the communities that are where people are enrolling, and would probably make this program contribute to making it a success, but there's no obligation to do that.
Yeah. I would also say there's something really important I want to say, which is that I made a mistake and I should know better. Yes, I know. I got a little curious during the break, and I looked up coverage of lactation services per se as a service. And there's a report from Kaiser that says only about 25 states explicitly provide it. Just between you and me, I think that's wrong. But I mean, I think there's an argument that it should be covered.
Yeah, not that Kaiser's wrong.
No, Kaiser's right.
Yes.
I think that it is wrong if states are not covering it, but that doesn't get you very much in a state that's not covering it. So mea culpa. I was being getting wild out there.
And
So,
let me
yeah.
I want to say one more quick thing about the outreach service thing, and I don't mean this to sound snarky at all, but when it comes to doing outreach services, whether it be provided, I'm familiar with this happening through the managed care context, but it not necessarily as managed care. Outreach and informing is more than hanging a something on somebody's doorknob. I'll just leave it at that.
Yeah. Yeah. So I've been asked to put a link to the flip chart in the posting it. I think you mean the chart book. I, for some reason, can't see how to post in the Q&A. Sadia, I'm sending this to you. Can you paste it in the Q&A?
But
Yeah.
there's two things. There's the chart book, which gives the 416 data, and then and that's on the Health Law website. And then there's the flip chart, which gives the EPSDT child scenarios, which is also on the website.
Yeah. Yeah, they're asking for a link, Jane. Do you think you can find it?
I do. I may be leaving you in looking, but let me give it a try.
Oh, the chat's been disabled and attendees cannot see the Q&A. I did not know that. Thank you. Anyway, here's a question. Can EPSDT be used to get treatment for a physical health issue that's not causing physical problems and doesn't meet coverage criteria to be addressed, but is causing serious mental health problems? My quick answer to that is yes. But I would say if it doesn't meet coverage criteria to be addressed, the coverage criteria are illegal. If there is a condition that is necessary to be corrected or ameliorated, and there's treatment that fits into a Medicaid box for it, I think that's a problem. And I'd be interested to hear more about that if you want to email me offline.
Yeah, I think too, where a physical mental issues can manifest themselves with physical problems, and a physical problem can manifest itself mentally. And Medicaid EPSDT doesn't have a cutoff. You have to take the child where they are and make an individualized assessment, so that those problems are coverable and should be covered.
Agree. How does EPSDT work with treating gender dysphoria and the transgender community?
So, oh, sorry.
No, go ahead. Go ahead.
We at the National Health Law Program have been engaged in litigation over this issue. We believe that that EPSDT does cover services needed by transgender youth, gender affirming care, the range of that care from puberty blocking medication to surgery, if it is necessary for the child. These services, we believe, just using the WPATH, which is the world recognized standard setting agency for services for transgender people, and those standards have been addressed by the American Medical Association, AAP, the American Psychiatric Association, the American Psychology Association. Within those standards of care, those services should be covered. And would be interested to hear from you if you are involved in a situation where they are not being covered.
Yes. Don't states need to amend their state plan to change from the free care restriction to how Medicaid can cover in schools? William? Glad you asked that question. One of the very first introductions we had to this issue was when we were asked, as in our capacity at the National Health Law Program, by the Healthy Schools campaign, to review state Medicaid plans to see if there was a free care restriction. We found only a few restrictions per se, but there were a lot of indirect restrictions that said school-based services are services that are included in an IEP. And so, yes, many states need to amend their state plan. In the guidance that you will see in this slide, the slides are going to be shared. The most recent guidance that came out last week, CMS listed 16 states that have amended their state plans to be sure that they can cover they can cover services that were formerly free care. And that is something that when I mentioned the administrative barriers that were making it difficult for states to do that, that is one of them. There are other things like billing, billing programming and the like that did it as well. But yes, that is an excellent question. And yes, it is true. And that's what's happening. That's why it's taken since 2014. Referring back to WIC and EPSDT, if the WIC clinic is within an agency that provides EPSDT services to children, could the WIC provider bill an interperiodic for height and weight checks and nutrition counseling, assuming the child has had a complete physical already? We're verging on an area that Jane and I are not that familiar with. We don't work with WIC, and that's probably like a state agency question. I suspect probably not. But again, that's I'm walking on thin ice talking. I don't have expertise about WIC. And I saw someone earlier in the Q&A said WIC does not provide lactation counseling services. So
I think on that, I agree, Sarah. I think that in this assumption here that the child has had their medical screen already, depending on the age of the child, they're going to have a midterm. Young children have multiple, in most states, multiple periodic screens over the course of the year. And then once they get a little older, it's an annual, in most states, periodic screen. So that having height, weight occur in the interim would not be recognized unless there were noticeable change in the child's weight, let's say. Then just to further clarify, the interperiodic screen, the idea there would be that the WIC person would say, hey, this child's weight has really gone down, we're worried. The interperiodic screen would be performed, as Sarah said, by the healthcare provider that is participating in the Medicaid program to determine whether follow-up treatment is needed.
Yeah. Are states, great question, very timely. Are states required to maintain or continue EPSDT services for individuals during the public health emergency if they reach age 21 during the PHE? Jane, I'm gonna let you answer that one.
Okay. There is litigation recently filed in Connecticut called Carr versus Becerra, which is challenging a rule promulgated during the previous administration, allowing states to terminate full coverage or terminate the coverage that people were receiving under certain conditions. The argument is that those conditions, the statute allows a couple of exceptions to continued coverage during the public health emergency. You voluntarily don't want the coverage, you die, things like that. But this this rule went further than that. This case is challenging those additional reasons why states can reduce Medicaid coverage. There are no plaintiffs in this case who are children. I will say that the argument that is being made logically would apply to children who age out of EPSDT. That's not those people in that setting are not part of that case, however.
I will say the back and forth about WIC continues in the chat. It sounds like the network could do something on WIC because there's a lot of interest in this. Someone says WIC does provide lactation services. It's not responsible for medical management of lactation. And that may be at the heart of what I was getting confused earlier with Medicaid. But again, this sounds like a subject there's a lot of interest in. Also in the Q&A, someone helpfully points out the child core set Notice of proposed rulemaking came out last week and would begin mandatory reporting in 2024. Yay. Let's see. I'm looking through to see if we've missed. This is a comment, not a question. Our state is not responsive to the make it available feature of Epsdt. I'm afraid that is a problem that we see, and we let me just be clear, we're wearing our hats as people from the National Health Law Program for a second. We have been involved in litigation where the gist of the claim is that there was a violation of Epsdt requirements to arrange for the provision of treatment by contract, directly or through contract. So that is
an example is that OB case that we talked about.
And that is the private, that is the core of the private duty nursing case claim. Let's see. Okay. Providers tell our families that they should skip the 30-month visit. We help families push back, but I'm interested in what's happening in other places. Where we sit, I haven't heard of this in the years I've been working on Epsdt, but we're not probably the first ones who would hear about it. I think that probably is not uncommon. And as children get older, it's, especially as kids get into adolescence, it's harder and harder to get them in for the services. And so, it may be that that's a common problem. And there's one last question, and I think we probably should wrap it up after that since we're a bit over. Wisconsin is a non-PRTF state, and providers routinely deter families from seeking Medicaid coverage for residential treatment. How can the make it available feature of Epsdt help here? For those of you not familiar with the term, PRTF is a psychiatric residential treatment facility, and it's a facility for children with behavioral health and mental health diagnoses. There was a lawsuit years ago about Indiana's failure to ensure that psychiatric residential treatment facilities were available, and they won. I don't know how successful ultimately the remedy was. So the theory, the basic principle is that if a service is covered, the state needs to ensure that it's available to people. And there's also an obligation for managed care plans to do that as well, if it is a service that's contained within their contract. So that is, that's one way that some advocates have pursued it. I will say that there's a lot of focus on advocacy and behavioral health to divert away from PRTFs and towards building home and community-based services. So that strain of advocacy also exists out there as well to ensure that alternatives are available.
Yeah, that's good. One quick thing to add to that, Sarah, is that back in October of 2021, CMS issued a bulletin to provide guidance to states on covering out-of-state services for children with medically complex, children with special health care needs. We certainly are not fans of out-of-state services. We are and have questions about the appropriateness of long-term residential placement, but there are short-term placements, obviously, that a child can need. So I don't know whether that October 2021 would help, but the state should be making progress toward and committing significant energy, given the crisis with behavioral health services, to, as Sarah said, making sure that there are community-based services and providers to provide them in the community rather than out of state or not at all.
Yeah. All right, everybody. So we've taken some of you, those of you who were able to stick with us over for 15 minutes. Gosh, we could talk about this all day. People have such good questions. For those of you who didn't get a chance to ask, I provided our emails in the chats. We're happy to answer more. I think you plumbed the limits of our knowledge about WIC. So hopefully there could be another webinar with some WIC experts someday. But anyway, so thank you very much for attending. And, I hope that we hear from more of you. There's more to be said, so much more on all these topics.
Yeah, thank you so much, everyone. We'll be sending out an email with a short survey and the slides and the recording of this webinar. Thank you to our speakers and thank you, everyone.
Bye.
Bye now.